Okay, welcome everyone. We're going to go ahead and get started tonight. I know one person is not going to make it, so I think we are all set to start. I said I would let you know about next week's classes, and as far as I know, the school is open Wednesday night, so we will have classes on December 21st. There will be no class the following week, which is the week of Christmas. So tonight we are going to cover chapter 14, and which is the basics of diagnostic coding. Next week we will cover chapter 15, which is the basics of procedural coding. And then again, the following week will be a week off, so you'll have time to catch up and get anything done that you may have fallen behind on. So the basics of diagnostic coding starts on page 255. We'll talk about what that is. We'll talk a little bit about the transition between ICD-9 and ICD-10. That transition has taken place, and it did go fairly smoothly. So just so that you know what was behind the scenes on that. How to look up codes should you need to, what diagnostic codes are used for, coding guidelines for accuracy, and some software that can also help with coding. So if you look on 256, the history of medical coding, they developed a classification system so that they could track people's illnesses and diseases. It went way back to 1893 was when it started. The list was revised at that point every 10 years. And then when the League of Nations came about in 1920, they saw a need for this classification system more widely for insurers, health administrators, hospital, and military as well. So the name was changed to International List of Diseases. When the World Health Organization in 1946 came about, they established codes for infections, diseases, parasites, symptoms, and causes of death. This was called Manual of the International Statistical Classification of Diseases, Injuries, and Causes of Death, ICD. So it's important to understand the differences between the two versions that we have. We have ICD-9 clinical modifications and ICD-10 clinical modifications. Right now, we are using ICD-10. ICD-9 was previous to that. ICD-9 was approved and put into use in 1975. The diagnosis codes had either 3, 4, or 5 characters. So the most characters you could have in a diagnostic code was 5. In 1995, the World Health Organization developed or approved to develop the International Classification of Diseases 10th revision, which is ICD-10. That was implemented in October 1st of 2015. So as history dictates, the purpose of medical coding was to collect statistical data. The United States is the only country in the world that uses coding for health insurance reimbursement. So providers are responsible for billing the insurance company for any services that were rendered, which is the office visit or the encounter or a procedure that a patient has done. During that procedure, we also have to collect diagnostic information, meaning why was the patient there? What were their symptoms, or what was or what is their definitive diagnosis? So the diagnosis is the determination of the nature of a condition, illness, disease, injury, or congenital defect. All components of the encounter such as the diagnostic findings, the procedures, and services are used to determine charges and to generate an insurance claim form. So what is diagnostic coding? It's taking a patient's diagnosis, such as abdominal pain, and translating it into a alphanumeric code. If you look back on a sample of a claim form, where the diagnoses go, there's really not a lot of space to write things out. So by assigning a diagnosis, a alphanumeric code, there is more clarification, and it makes it simpler for insurances to process the claims. ICD-10 code identifies the disease or injury for which a patient was treated. It has up to 7 characters with a period after the 3rd character. So ICD-10 can help ensure accurate health record documentation and efficient claims processing. ICD-10 is available as online documents from the Center for Medicare and Medicaid Services, as a manual, this is one sample. The manual can be published by several publishers. So different publishers can use different layouts, different symbols, different color coding, and some other different features or layout their tables different. So what you will want to do is, if you do find yourself having to use an ICD-10 book, get one that you feel comfortable using. Some give definitions, some give great diagrams, so whatever you're going to be comfortable using. When you use ICD-10, you chose a standardized alphanumeric code for the diagnostic statement, and your diagnosis comes from your op reports, your office notes, labs, x-ray reports, anything like that can come from a history and physical, and the documentation needs to support what is being coded as their diagnosis. ICD-10 also keeps track of various health statistics related to disease and injury. Practice management software, clearinghouses, and mostly all third-party payers recognize these codes, which simplifies the reimbursement process. So just a little bit on the transition from ICD-9 to ICD-10. On the top of page 257, there's a diagram that shows ICD-9 had 3 digits, a period, and then could have 2 additional digits, but the most it would have would be 3 to 5. ICD-10 has 3 digits, and then a period, and then the capability of 4 more digits. So the most a code would have in ICD-10 is 7 characters. You can see on table 14, again, ICD-9 was 3 to 5, ICD-10 3 to 7. The first character in ICD-9 was either numeric or alpha, and in ICD-10 it is strictly alpha. Characters 2 and 3 in ICD-9 were numeric. In ICD-10 they're also numeric. But characters 4 and 5 in ICD-9 were numeric, but 4, 5, 6, and 7 in ICD-10 can either be numeric or alpha. In 9, you would always have at least 3 characters, no less. ICD-10, the decimal is after the 3rd character. ICD-10, 9, decimal also after the 3rd character. And ICD-10 uses all letters in the alphabet except for U, and we'll go over why. So mainly the transition between ICD-9 and ICD-10 was taking the codes that we used for diabetes, for example, which used to be 250.00. And that diabetes code was now going to transfer to something completely different in ICD-10. So it did not change the way we looked up the codes at all, but it could be now up to 7 characters. So what they did is they came up with these general equivalence mappings, or what we call GEMs. And what you could do is you could use these mapping systems to look up the code in the ICD-9 format, and it would crosswalk you to what the possible codes would be in ICD-10. So that was good. It gave us an idea. But for some of the fracture codes, for example, in ICD-9, there used to be one fracture code for a distal radial fracture. Well, when that crosswalked to ICD-10, we now have a possibility of, I think it's 12 codes or more, depending on which arm it is, the type of fracture it is, whether it's open or closed. So ICD-10 gave us more codes that we could pick for the one code that we used to use in ICD-9. So as a medical assistant, you may have some coding. So you'll be familiar with how to look up ICD-10 codes. You probably are not going to have to map ICD-9 to ICD-10 because it has been in effect 2 full years now, so mostly everything has been transitioned. The only reason you would come across ICD-9 codes is, God forbid, but if a claim prior to October 1st of 2015 was being appealed or reversed or addressed, then you're going to have to dig through and be familiar with those old codes. But it should be all transitioned now. So on page 258, the structure and format of ICD-10. ICD-10 has a tabular list and an alphabetical index. Pretty straightforward. The alphabetical index in this particular version that I have, the alphabetical index is in the back, and the tabular index is in the front. If you ever took my billing and coding, my coding class, you will hear me say we always look codes up alphabetically. It will lead us to 1, 2, possibly more codes. It will lead us in other directions. And then we always go to what's called the tabular, or I like to call it the numeric, and we look up that code and we read the full description. Because by reading that full description, sometimes it's italicized in the numeric listing, and if it's italicized, it means it can't be coded first. But looking it up alphabetically, that is not going to tell us that information. Looking it up numerically also gives us other information if other things could be coded in addition to that, or if we need to use additional codes to help describe something. Every year, the Centers for Medicare and Medicaid review ICD-10 coding, and it is updated and published for use October 1st of every year. It will have additions, revisions, and deletions to the diagnostic codes, code descriptions, and guidelines. And it's very important that come October 1st, you are using that current version of ICD-10. That's why we are using the 2018 version now. If you are using an old, even last year's 2017, it is possible you could be using an outdated code that is no longer valid. And if you submit that on your claim forms, the claim will be denied and sent back to you for reprocessing. So again, always use the current year's coding manuals. The CMS prepares guidelines for coding and reporting with the ICD-10 codes, as well as instructions on how to report codes on the insurance claim form. The guidelines are a set of rules that have been developed to accompany and complement the conventions and instructions in the ICD-10. So it's actually giving us additional information to help us code and submit claims properly. So the alphabetical index, is just that, alphabetical list of diagnostic terms and related codes. The index has main terms, non-essential modifiers, essential modifiers, and subterms. So your main terms would appear in bold, and you can see in the next column over, colitis, that would be an example of the main term as it is bolded. The non-essential modifiers, they follow the main term. They are enclosed in parentheses. They are supplemental words or explanatory information, but they do not affect the code assignment. So in this instance, after colitis, you see acute, catarrhal, chronic, non-infective, and hemorrhagic. All of those pertain to that code that is right after it. It just gives supplemental information but does not affect the code assignment. The essential modifiers, they are indented one space to the right under the main term. They change the description of the diagnosis in bold type. And then your subterms are indented one space to the right under the essential modifiers, so 2 spaces under the main term. These diagnoses are used when all conditions exist. So again, for colitis, if you go down underneath giardial colitis, it says A07.1. So we would in turn then go to that code in the tabular listing, read it, and it would say that it was a giardial colitis. Might give you a little bit more of a definition of what that is, and if that matches what supports our documentation, then that is the diagnosis code that is used. On page 259, this is how the chapters are broken down in ICD-10. So chapter 1 is infectious and parasitic diseases. Chapter 2 is neoplasms. 3, disease of blood and blood-forming organs. 4 is endocrine. 5, mental behavioral. 6, nervous. 7, eye and adnexa. 8, ear and mastoid. 9 is circulatory. 10, respiratory. 11, digestive. 12, skin and subcutaneous. 13, musculoskeletal and connective. 14, genitourinary. 15 is pregnancy and childbirth. 16, conditions in the perinatal period. 17, congenital malformations, chromosomal abnormalities. 18, symptoms, signs, and abnormal lab findings. 19, injury, poisonings. 20, external causes of morbidity. And 21, factors influencing health status and contact with health services. In the second column, it gives the code range, so you have an idea, and then it gives an example of one type of diagnosis that you would find in that particular chapter. The alphabetical index does have 2 tables. It has a table of neoplasm, and it has a table of drugs and chemicals. The table of neoplasms is at the end of the alphabetical index. And I know it's kind of hard to see, but what it does is it's a great big table, and the first column gives you the body part for the neoplasm, and then it gives us 6 choices for helping to pick that type of neoplasm for our code. So if it is malignant and it is the primary site, it comes from column 1. If it's malignant but a secondary malignancy, it comes from column 2. If it's carcinoma in situ, 3, benign, the 4th column, uncertain behavior and unspecified behavior. So we have 6 different columns, and we'll go over what those columns are. And then after that one, we have a very similar looking table, but it's the table of drugs and chemicals. So it gives you all of the drugs here, and then it again gives us 6 different columns that we can help to select our code from. Poisoning accidental or unintentional, poisoning intentional, poisoning assault, poisoning undetermined, adverse effect, or underdosing. And again, by looking at the code here, we still take this code and go to our numeric listing and look it up and make sure that the description fits, because sometimes we can read one word differently and it can change the whole scenario. So table of neoplasms, table of drugs and chemicals. On page 260, again, the tabular list is what I call the numeric. Of course, in ICD-10, it's alphanumeric. But it is divided into 21 chapters that I just went over. Some chapters use a body part or an organ system to group the codes. So in chapter 8, we had the eye and adnexa, just to give you an idea. Each chapter is subdivided into subchapters or blocks, and each subchapter has a designated 3-character code. All the 3-character block codes begin with an alphabetic letter assigned to that chapter. So again, if you're looking down at the bottom here, the male genitals have a code in the N section. So N is assigned to that particular section in the book. ICD-10 is produced again by a variety of publishers, but the information that's in it, the elements, are always the same regardless of the publisher. So again, get something that is easy, familiar for you to use. The alphabetical index works, again, just like a dictionary. It's got guide words up at the top, which are the first and last words on that page. So again, very similar to a dictionary. Each chapter of the tabular list has a different color-coded border. In some manuals, the strip shows the chapter title and the range of codes. In other books, it may just give you the range of code numbers. So familiarizing yourself with these tools can help improve your proficiency and help you know how to use these manuals. It's important to note that some codes do not need to be extended beyond the 3-character code. So just as in ICD-9, we could have a 3-digit code, we could have a 4-digit code, or we could have a 5-digit code. Some were valid with only 3 digits. It is the same in ICD-10, except they're alphanumeric. So, for example, essential hypertension, I10, does not need any more digits. It is a valid 3-digit code. But you can have another one that needs all 7. So again, knowing how to use the books and look things up will help us get to that point. Conventions used in the tabular listing. Conventions can be abbreviations, punctuations, symbols, instructional notations, anything that helps the coder select accurate specific code. They are found in the tabular list, but not in the alphabetical index. So yet another reason why we do not code just strictly from the alphabetical index. In ICD-10, they created a dummy placeholder X. It is used in 2 different ways. The dummy placeholder can be used as the 5th character in certain 6-character codes, and that way it allows for future expansion of the code. So if it's used, you look at 14.1 example, using the dummy placeholder for a 5th character, T43.4X1A. Some categories will have a 7th character, and that is the additional add-on. But you can see that the dummy placeholder can be used in the 7th character codes as well. S50.01XA. So it's either going to be your 5th digit or your 6th digit will be a placeholder, or can be a placeholder in some codes. The 7th character, if you look down at figure 14.5, for those particular codes, the S50 or the S03, A for initial encounter, D for subsequent, and S for sequelae. So the initial encounter would be the first time the physician sees the patient. D, subsequent, they are coming in for follow-up. And then the sequelae would be something your provider would have to let you know that that is the reason the patient is being seen for. Punctuation on 261, 4 basic forms of punctuation used in the tabular list: brackets, parentheses, colon, and braces. Each one has a different purpose to help read and understand the code descriptions. If you look down below, here's the punctuation. So your brackets enclose synonyms, alternative wording, or explanatory phrases. Your parentheses enclose supplemental words which may be present or absent in the statement of a disease or procedure. These words do not usually affect the code number, but they give further definition. The colon is used in the tabular index after an incomplete term that needs one or more of the modifiers or adjectives to help pick the code. And then the braces enclose a series of terms, each of which is modified by the statement appearing to the right of the brace. So those are the punctuations. We have instructional notations, which can be found in both alphabetic and the tabular list. Some of them are located directly under the main term. One of them is includes. The word includes, used in the tabular list, clarifies conditions included within that particular chapter. Includes note begins with the word includes when they appear at the beginning of a chapter, section, or category. At the code level, the word includes is not present. Only a list of terms included in the code is provided. Excludes. In ICD-10, they use 2 types of exclusion notes: exclude 1 and exclude 2. So if you were looking in the ICD-10 book under a particular code and it said exclude 1, this is clear. It means not coded here. So this code should never be used. It means that the excluded code should never be used with the code above the exclude 1 note. So for example, G14 is post-polio syndrome. It has an exclude 1 note about sequelae of post-poliomyelitis. So those would never be coded together. So that would never be coded with that code. Excludes 2 means not included here. The condition is not part of the condition represented by the code. However, a patient can have both conditions concurrently. So there is a corresponding code for the excluded conditions. When an exclude 2 note is present, the coder may code both conditions if they present with both. So exclude 2, if they present with both, you can code both. Exclude 1 means not coded here. They are not going to go together. You are also going to see notes that say code first or use additional code. Code first appears under manifestation codes. Manifestation codes specify how an underlying condition appears or how it manifests. So a code first note indicates that the underlying condition must be sequenced first before the manifestation code. So for etiology and manifestation combination codes, it will say use additional code. The code first and use additional code notes indicate the order in which the codes are arranged. So if it says code first, the underlying disease, then the underlying disease is going to go before this particular code. If it says use additional code, that means it's going to follow the code we have already selected. There are going to be some cross-reference notes. Cross-reference notes in the alphabetical index instruct the coder to check elsewhere in the index before assigning a code. So you will see the word C. The C note follows a main term. It directs the coder to another main term. So acetopenia, there may not be any numbers listed under that. It tells you to go see a granulocytosis. C also follows a main term. It indicates that another main term may be checked that may provide additional useful index entries. So adiposis. C also obesity. So in this case, we may find a code under adiposis, but it's telling us before we pick a code, let's also go see obesity to see if it gives us more specific information. And then C category directs the coder to a specific category. For example, your main term, intoxication. The essential modifier meaning inebriation. C category F10. So it's going to lead you to where we need to start. There's some relational terms in both alphabetical and tabular to clarify context of a disease or injury, and, with, or due to. And in the tabular list, and should be interpreted as meaning and/or. With should be interpreted as meaning associated with or due to when it's in the alphabetical index. And the words due to in both tabular and alphabetical index, the term due to signifies relationship between two conditions. In your ICD-10 book, as well as in the old ICD-9, we have coding guidelines. The coding manual begins with the coding guidelines, and there are guidelines for each section in your ICD-10 book. The guidelines are a set of rules that have been developed to complement the official conventions and instructions for ICD-10. Section 1, the guidelines are organized into 4 sections. Section 1, general coding guidelines and chapter-specific guidelines. Section 2, how do we select the principal diagnosis for non-outpatient. Section 3, reporting additional diagnoses, and Section 4, outpatient services. These guidelines in your ICD-10 book are right in the front of the book. It tells you how to use the book, about the color-coded, and then ICD-10 official guidelines. And what I have found with these is that I don't, for instance, use the pregnancy chapter. I use more of the orthopedic in our specialty. So you would find more notes in that section for me. But if somebody is taking the coding exam, everything you need to pass the exam are in the books, your reference books that you are using, including the guidelines. Again, telling you, for example, an italicized code cannot be listed first, or about the code first, or use additional codes, stressing the importance that if it says code first, that other code needs to be in front. Preparing for medical coding. So to do this, we abstract the diagnostic statement documented in various reports. For most of us, this is going to come off the encounter form or the super bill that is generated by your practice management system or electronic health record. Typically, this is going to be coded by your provider. Your provider on these super bills or encounter forms will let you know what they have done for that patient and what their diagnosis codes are. It may just be one, or it can be more than one. What the doctors don't know is what order those diagnosis codes possibly need to go in. Usually, rule of thumb, if it doesn't fall under the guidelines, they go in order of
urgency or most severe. But when we look them up alphabetically and get our codes, the one that we think is, or the one that the doctor said is the most severe could be italicized, which means we can't use that first. So we would then have to use one of the other codes that they have selected. But again, typically they are going to be selected by your provider. If you do use an encounter form, that encounter form needs to be reviewed annually because, as I said, these codes change October 1st. So if diagnosis codes change that are pertinent to your practice, they also need to change on your encounter form, or the incorrect diagnosis codes could be being used on your claim forms. You can abstract diagnosis codes from the history and physical. The history and physical is a statement in your patient's own words for why they are seeking medical attention. It's also called the chief complaint. After they do that, the provider documents any other pertinent history, social, past family, anything like that. After the patient's history is the physical exam, and that is both objective and subjective. And then they provide an assessment. This is the evaluation of the findings and includes a diagnostic statement. The plan is the treatment plan for the conditions that are noted in the assessment. So that can be ordering x-rays, ordering labs, scheduling a surgery, providing medication or prescribing medication. Treatment notes are the second most common medical documentation from which diagnostic codes or statements can be extracted. And your treatment notes, most of your doctors dictate them in what we call SOAP format, which is subjective findings, objective findings, assessment, and plan. So it's easier for them to lay it out that way. It's in the order in which they do their assessment. The discharge summary can also provide diagnostic information for patients who are hospitalized. The main elements of a discharge summary are the patient's admission date, date of discharge, and clinical course during hospitalization. And again, diagnostic statements can be abstracted from the discharge diagnosis section. Operative report, so a patient having surgery, there's typically a pre-operative diagnosis and a post-operative diagnosis. So we are able to pull that information out should we need to. And then radiology, lab, and pathology reports can also be used to help us pull diagnostic information on a patient. So, steps in ICD-10 coding. There are 8 basic steps. The first step is abstracting the diagnostic statement from the health record. Again, this is probably going to be from your encounter form that your doctor has already provided you these codes. The next steps are performed by using our ICD-10 book, the alphabetical index, to help search for the code or code ranges. The remaining steps are then you taking those codes from your alphabetical index, going to your tabular list to confirm that code, and match the description. And we want to make sure it matches to the most specific and accurate diagnostic codes. Because, like I said, you will see that sometimes one word can change the whole meaning. So if you look on 264, this is just showing an example of how you would go about looking up a diagnosis for Parkinson's disease. If you look up the main term Parkinson's disease, syndrome, or tremor, in the alphabetical index it tells you to just see Parkinson's, period. So you look up that main term and it gives you a code of G20. But you also have to look at the essential modifiers, which are the ones that are indented underneath. So in this case, you can see Parkinson's with neurogenic orthostatic hypotension, or Parkinsonism arteriosclerotic, Parkinsonism dementia, Parkinsonism due to, Parkinsonism secondary Parkinsonism, vascular. So depending on what type of Parkinsonism or Parkinson's, then that could be a completely different code than the G20. That just is for Parkinsonism. So you chose the correct essential modifier based on the diagnostic statement. In this case, they just do the G20 because there were no other specific information. Check for any coding guidelines, conventions, or notes about that. So under G20, that particular code G20 includes hemi-Parkinsonism, idiopathic Parkinsonism, perilous agitans, Parkinson's disease not otherwise specified, but excludes primary Parkinson's disease dementia with Parkinsonisms. So if we were looking for Parkinson's disease dementia with Parkinsonism, it leads you to a completely different code, because remember, if it's exclude one, it can't be coded there. You're going to go to another code. So in this case, the final code would be G20 for Parkinsonism. The next couple of pages go over the SIM chart, where it's an encoder software that helps you look up codes. You can also, I use Google a lot, and I will type in ICD-10 code for a certain disease or illness, and it will bring it up that way as well. You can look at what's around there, or there, again, if you do not want to purchase books, because the books can be pretty expensive. Some practices prefer to use the software because it may be a little bit less expensive, and it still allows you to look things up the same way. It's just you don't have a paper version. You're looking at it on the computer instead. So again, using the alphabetical index, you look it up alphabetically, you get a code or code range, and then we go to the tabular list or the numerical listing to check the conventions, the punctuation, any notes or guidelines before we actually select a code. Never assign a code directly from the alphabetical index, even if there is only one code. And I mentioned that in the table of drugs and chemicals as well. Just because it gives you one code, don't assume that that is correct. We want to go make sure. We want to read those descriptions. Sometimes in those tables of drugs and chemicals, it may not give you the additional digits. So if you were to use that 4-digit code that's there, it could be incorrect because it may require 5 digits, and you're not going to know until you go to the tabular to look it up. On 268, again, note your non-essential modifiers. So in this case, the word cyst had sebaceous after it, so that is a non-essential modifier. And then you can see in figure 14.9, cyst of the eyelids, sebaceous cyst, H02.82. In our ICD-10 book, that would have a code or a mark next to it. In my book, actually, it's red because it tells me it needs additional digits. So in this case, it would need a 1, 2, 3, 4, 5, 6, or 9 after it, and it specifies which eyelid that sebaceous cyst is pertaining to. Using a tabular list, so once you identify the code from the alphanumeric, you go to your tabular, you look up that code. You will note if any additional characters are needed. Again, depending on the publisher, that might be done by a plus sign. In this book that we use for my coding classes, the code has a red block over it, so that tells us it needs more codes. So again, it varies by the publisher. You can also use encoder software. This will help you select the codes accurately. You type a few keys into the search box. They find the most likely matches. Then you have to click on the specific code to expand and get further details with the additional codes. It's important to understand coding guidelines. Again, remember that all ICD-10 manuals, regardless of the publisher, do have instructional notations to help the coder select the code more accurately, as well as the coding guidelines. They are all published in the book yearly. When any discrepancy occurs between reference sources, the current year's ICD-10 coding manual is the final authority. So if by chance you were looking at last year's 2017 versus this year's would trump on that. When coding, always refer to and thoroughly review the conventions, the instructional notes, the guidelines, anything like that for helping to select the appropriate code. In the doctor's office, we can code signs and symptoms. So what that means is a patient comes into the office for abdominal pain. We see the patient, doctor doesn't have any definitive diagnosis as to what is causing that abdominal pain, but he's going to order some tests. So today's diagnosis, we can code the patient's symptoms, abdominal pain. So the patient goes and has some lab work, maybe an x-ray, doctor tells them to come back in a week. When they come back in a week, those results are reviewed, and let's say that it gives the patient a diagnosis of appendicitis. So that visit now is going to have a definitive diagnosis of appendicitis. We now know what is causing that patient's abdominal pain. So the signs and symptoms we no longer use. We would use a definitive code instead. In the doctor's offices, sometimes, a lot of times, you will see the doctors, like on that lab test for abdominal pain. It would say diagnosis abdominal pain, but the doctor might also put rule out appendicitis. There are no codes for question of, rule out, probable. So you cannot code something that is questionable. You refer back to the signs and symptoms. So do not try to look for a code for a rule out, a question of. In your tabular list, ill-defined conditions, signs, and symptoms would be in chapter 20. Again, it's not a memorization game. You don't have to remember which codes are in which chapters. When you look them up alphabetically, it would end up leading you to the tabular section of chapter 20. Your signs and symptoms include not elsewhere classified cases. Signs and symptoms existed on the first encounter for which something could not be definitively determined. Conditional diagnoses for a patient who failed to return for further care. Medical cases referred elsewhere for treatment before a diagnosis could be made. Not otherwise specified cases in which a more precise diagnosis was not available. Certain symptoms for which supplementary information is provided that represents important problems in the medical care provided. So again, signs and symptoms are okay to use if we do not have a definitive diagnosis. Etiology and manifestation. Etiology refers to underlying cause or origin of a disease, and manifestation describes the signs and symptoms of the disease. Etiology code always listed first. Manifestation code would be listed in addition. Again, it's up to our doctors to tell us if it's etiology and manifestation. It's not up to us. We are not the trained medical profession, so that's why we rely on the providers to put that information on the super bills. Multiple coding, in addition to signs and symptoms that require 2 codes to fully describe a single condition code. We may have other single condition codes that may require more than 1 code as well. So here is where you will see that use additional codes. The sequencing rule is the same as for etiology and manifestation. Use additional code indicates that a secondary code should be added after the condition code or after the primary code. So a bacterial infection, a secondary code may be required to identify the organism. Now, sometimes we don't know what the organism is, and that's fine. It will say use additional code. That doesn't mean we have to use it. It means that if we are provided that information, we should be using it. Code first notes are used for certain conditions that involve both an underlying etiology and multiple body manifestations. A code, if applicable, any causal condition first indicates this code may be assigned as a principal diagnosis when the causal condition is unknown or not applicable. And multiple codes can be needed for sequelae and complications. Sequelae is what we call a late effect code. They are lingering effects produced by a health condition after the acute phase of an illness or injury. The acute phase is considered the first 30 days of a condition with no improvement. There is no time limit on when a sequelae can be used. Residual effect can appear early, as in a stroke, or it can occur months or years later. So a lot of people that do sports, they can have the years later with osteoarthritis in their joints, for example. Coding of sequelae generally requires 2 codes sequenced in the following order. The original condition or nature of the sequelae sequenced first, and the sequelae code sequenced second. There is an exception to that guideline. Instances when the code for the sequelae is followed by a manifestation code. The code for the acute phase of the illness or injury that led to the sequelae is never used with a code for the late effect. And if you look down underneath that, there's a blue box that are rules for coding impending or threatened condition. If a patient is admitted to the hospital, at the time of discharge, if something is documented as impending or threatened because they were an inpatient, you code it as if it occurred, so it is confirmed. If it did not occur, you consult the alphabetical index to determine whether the condition has a code for impending or threatened. And if the subterms are listed, you can assign the given code. If the subterms are not found, you code the existing underlying condition, signs, or symptoms of the condition described as threatened or impending. So that's a guideline for somebody who was an inpatient. In the doctor's offices, we do not code a threatened or impending as if it existed. But that's a specific guideline for a patient who is being discharged from the hospital. A complication of medical care generally requires additional codes. Sometimes the complication may not be mentioned as part of a diagnostic statement, but it can be the result of a reduced reimbursement. So if there is a complication, we want to stress to our provider that if we can code that complication, then it may help reimbursement. He may not take a reduction instead. Keep in mind, not all conditions that occur during or after medical care or surgery are considered a complication. In order for it to be a complication, it needs to have a cause and effect relationship. between the care provided and the condition, and the documentation needs to indicate that the condition is a complication. Coding infectious and parasitic diseases. Again, multiple codes are needed to code infectious or parasitic diseases. First code identifies the disease or condition, and the second code identifies the organism that is actually causing that disease. Coding organism-caused diseases. There is a two-step process. Begins with the affected anatomical site. So we have a throat infection caused by enterovirus. We are first going to code the throat infection or pharyngitis. And in the tabular list, that would lead us to J02.8. Underneath that would be an instructional note that says, use additional code to identify infectious agent. So in this case, we know what the infectious agent is. It's enterovirus. So underneath that list, it's going to give you some codes. You would select the one for enterovirus, and we would use B97.1. Again, it does require a fifth digit. That fifth digit, it says, does not have any other additional information in the medical record, so they're not able to be specific. So they use a unspecified fifth digit. HIV and AIDS. HIV, it's important to use HIV and the AIDS codes properly. HIV indicates that only the virus is present, and AIDS is a syndrome. It's a group of symptoms occurring together. Never code a patient as having HIV unless it is clearly documented as confirmed. Probable and suspected are never coded. Remember, there are stringent restrictions placed on disclosure of medical information for HIV and AIDS related testing. If a patient is admitted for an HIV-related condition, the principal diagnosis would be B20, which is HIV disease, followed by the additional diagnostic code for the related condition. If the patient has HIV disease admitted for unrelated condition, the code for the unrelated condition is the principal diagnosis. And then the B20 would be used in addition. HIV in pregnancy and childbirth. Because of an HIV-related illness, it should receive a principal diagnosis of O98.7, which is HIV complicating pregnancy, followed by the B20. So there's a specific code for it complicating pregnancy, and then the code for the HIV. Patients with asymptomatic HIV who are admitted during pregnancy should never receive the codes of the O98.7, which is the complicating pregnancy. There is a asymptomatic Z21. Encounters for testing HIV. If they've been seen to determine whether they have the HIV status, there is a Z11.4, encounter for screening for HIV. If a patient with signs or symptoms is being seen for HIV testing, code the signs and symptoms. There's an additional code for the counseling, Z71.7. I mentioned earlier that your ICD-10 book has two tables. This table, the neoplasm. This neoplasm is a new growth. It's coded by site or location of the neoplasm and the type of behavior. They list them again by anatomic site in alphabetical order. And then there are 6 possible code numbers for each anatomic site, depending on whether the neoplasm is malignant or benign, uncertain behavior, or unspecified nature. So here, terms defining malignant neoplasm sites. Primary identifies the original or originating anatomic site of the neoplasm. So that's the original site of the cancer. It's where it started. Secondary identifies the sites to which it may have spread. Carcinoma in situ is defined as the absence of invasion of surrounding tissues. So the CA in situ column would only be used if your doctor specifies that. So the CA in situ is like it's enclosed in its own little ball. It has not spread to any other tissues. So they usually can go right in and take out that ball, and they've caught it. Benign, uncertain, or unspecified. So benign means the growth is non-cancerous, non-malignant. It has not invaded adjacent structures. Uncertain behavior means the pathologist is unable to determine whether it's malignant or benign, so maybe they didn't get enough tissue. Unspecified, neither the behavior nor the histological type of neoplasm is specified in the diagnostic statement. So again, picking the column is going to depend on what type of cancer it is. Again, the in situ would only be used when the doctor specifies in situ. So 6 steps for coding neoplasms. Using your table of neoplasms, determine the anatomic site, determine whether the neoplasm is malignant or benign. If the neoplasm is benign, select the column in the table by reviewing your diagnostic statement. If your neoplasm is malignant, again, determine the table column that best fits its behavior. Malignant primary, malignant secondary, or carcinoma in situ. Link your appropriate column to the appropriate row, and then take that code and check it in the tabular list to make sure it complies with guidelines, instructional notes. Again, your ICD-10 manual provides additional information, definitions, and guidelines for coding neoplasms, just as it does other sections of your ICD-10 book as well. Coding diabetes, diabetes mellitus, DM, classified as type 1 or 2. Type 1, develop the disease because your pancreas cannot produce insulin. Type 2, your pancreas becomes unable to maintain the level of insulin in the body needed to function. So in ICD-10, the diabetes codes are combination codes, so they include the type of diabetes, the body system affected, and complications affecting that body system. So these codes should be sequenced according to the reason for the particular encounter, and you can assign as many codes from the diabetes to identify all patients' associated conditions. In ICD-10, your primary codes for diabetes E08 to E13 do not include whether your patient is using insulin. So there is an additional code, Z79.4, long-term or current use of insulin. That should be assigned in addition if your patient is using insulin. On page 272, gestational diabetes. This is pregnancy-induced. It can occur during 2nd or 3rd trimester. They may not have ever been diabetic before. It just happens in pregnancy. Codes for gestational diabetes would be in the 024.4 section. No other code from this category 024 needs to be used. There's 0244, which includes diet controlled, and then there's one for insulin controlled as well. The Z79.4, the long-term current use of insulin, should also be assigned with the 024 code if they are indeed taking insulin. There's an abnormal glucose tolerance test in pregnancy, 099.81. So sometimes they have one that comes back abnormal. This would be the diagnosis if it's abnormal If they go through another one and it's actually documented as gestational diabetes, then it would refer back to that O24.4. Circulatory system. Providers use lots of phrases in the circulatory system. The coder must carefully review all inclusions, exclusions, conventions, and instructional notations in the circulatory system. So if you look under here, we have myocardial infarction, or MI. It can be coded as acute if it is documented and stated as a duration of 8 weeks or less. It can be coded as chronic if it is so stated in the diagnostic statement or it's been longer than 8 weeks. Other MI coding considerations: if an MI is specified as old or healed, it should be coded using category I-21. History of MI uses codes I-25.2, old myocardial infarction. If your patient is symptomatic, code the underlying condition or symptoms only if the underlying condition is not known. So again, your physician will be telling you whether it's acute or chronic or old or healed, but we need to know that specific information. We're not going to be able to select a code without it. In coding hypertensive disease, a distinction is made in ICD-10 between elevated and high blood pressure. High blood pressure is defined as hypertension, I-10. If the statement does not contain the word hypertension or the phrase high blood pressure, then the condition is referred to as elevated blood pressure, RO3.0. So you don't give somebody hypertension or high blood pressure unless it's specifically documented as high blood pressure. If there is a cause and effect relationship between hypertension and heart disease, it needs to be clearly documented in the record so that we can select the appropriate code. The hypertension table in ICD-9, they did not carry forward to ICD-10, but you are still able to select a appropriate code depending upon what is going on with it. So if you look at the figure 1412 on the bottom, in ICD-9 we had a grid. So if it was hypertensive heart disease, we had a choice of it being malignant, benign, or unspecified. In ICD-10, that now translates to one code: hypertensive heart disease without heart failure. So they took away the codes for malignant, benign, and unspecified and just reworded it differently. So again, the hypertension, if it has hypertensive heart disease, there needs to be a causal relationship documented in the health record between the hypertension and the heart disease. Same thing for chronic kidney disease. Assign codes from category I-12, hypertensive chronic kidney disease, when there is both hypertension and a condition for chronic kidney disease. Unlike hypertension with heart disease, here your ICD-10 presumes that there is a cause and effect relationship. So the other one, we had to make sure there was a cause and effect relationship. Here for chronic kidney, ICD-10 presumes that there already is. Atherosclerotic cardiovascular disease. ICD-10 has combination codes for atherosclerotic heart disease with angina pectoris, which is chest pain. I-25.11. Atherosclerotic heart disease, native coronary artery with angina pectoris. And I-25.7, atherosclerosis of coronary artery bypass graft and coronary artery of transplanted heart with angina pectoris. When you are using one of these combination codes, you do not need to use an additional code for the chest pain, because that code in the description already says angina pectoralis. So we don't need to go pick the code just for the chest pain. This code includes it. A causal relationship here can be assumed in a patient with both atherosclerosis and angina. If a patient with coronary artery disease is admitted because of an acute myocardial infarction, the heart attack code would go before the atherosclerotic coronary artery disease. And again, this is all in the guidelines of what can be coded first and what should be, but again, just giving you little tidbits. Skin ulcers, codes from L89 are pressure ulcers. They're combination codes that identify the site of the pressure ulcer and the stage. Stages of pressure ulcers are based on severity. So we have stage 1 through 4, unspecified stage or unstageable. So if it's unstageable, it's usually that it cannot be clinically determined. These codes also are used for pressure ulcers documented as deep tissue injury. Complications of pregnancy, childbirth, and puerperium. Coding for OB is like using a specialty code book. There's a lot of codes that can be used, so it is important to know the guidelines should you be coding obstetrics and pregnancy. Some terms you will hear will be antepartum. This is pregnancy applying as soon as pregnancy test result is positive. Childbirth, meaning delivery. Postpartum or puerperium, the first 6 weeks after delivery, and peripartum is the period from the last month of pregnancy to 5 months postpartum. The OB codes are in chapter 17, and they have sequencing priority over codes from other chapters, meaning if the mom is pregnant and she comes in with an ear infection, the pregnancy code is going to go first, and then the ear infection. There is a code Z33.1, pregnant state incidental. It is the provider's responsibility to state the condition being treated is not affecting the pregnancy. Most of the codes in Chapter 17 have a 6th character, which identifies the trimester of pregnancy. So it's important for the provider to be documenting how many weeks, and then it can be figured from there which trimester they are in. So again, documentation. When a patient is admitted to a hospital for complications in pregnancy during a specific trimester, and they are in the hospital until the next trimester, the trimester for the antepartum complication code should be assigned on the trimester in which the complication developed, which means it's going to be when they were admitted. So if they were admitted during trimester 2, but they ended up staying until trimester 3 because they were in that week's window, we would code by the trimester 2 for that particular admission. The 7th character is for fetus identification. So single gestation, multiple gestation, and so forth. When the documentation in the record is insufficient to determine whether the fetus is affected, we may need to get clarification, or we can use a unspecified code. If it's more than one fetus, when it is not possible to determine clinically which fetus is affected, we use the 0 or the unspecified code as well. Outcome of delivery and live-born infant codes. When a delivery occurs, the principal diagnosis corresponds to the main circumstance or complication of the delivery. In the cases of cesarean section, the selection of the principal diagnosis is the condition after the encounter responsible for the admission. So if they were admitted with a condition resulting in the performance of a C-section, the condition should be selected as the principal diagnosis. If the reason for admission was unrelated to the reason that she had the C-section, then the condition related to the reason for admission or encounter would be sequenced as principal. There is a outcome of delivery code Z37. This is always included in the maternal health record when a delivery has occurred. Code 080, encounter for full-term uncomplicated delivery, should be assigned when a woman is admitted for a full-term vaginal delivery and delivers a single healthy infant without any complications. So again, that 080 strictly for full-term uncomplicated vaginal delivery. Newborn coding, that comes from chapter 18. Your perinatal period extends just before birth through day 28. So when you code the birth episode in the newborn health record, it's Z38, live born infant according to place of birth. So the mom gets an outcome of delivery, Z37, the baby gets a Z38. And again, the infant code only gets used on the infant record or the newborn record, and the mom's code only on the mom's record. Coding for injuries. When you code injuries, you can assign a separate code for each injury unless there is one code that describes both injuries that you happen to be looking for. The code for the most serious injury as determined by the provider would be sequenced first. The superficial injuries that go along with some of those, such as the scratches and the abrasions, are not coded when they are associated with more severe injuries. So somebody that's fallen and broken their arm that has cuts and abrasions, we're not going to code the cuts and abrasions. We focus on the broken arm. Primary injury resulting in minor damage to peripheral nerves or blood vessels. The primary injury is sequenced first. Any additional codes for injuries to nerve, spinal cord would be coded as secondary. Coding traumatic fractures. The principles of multiple coding of injuries needs to be followed in fractures. Fractures of specified sites are coded individually by site with the level of detail in the health record. Your traumatic fracture codes, there is an A02 and then they go into the S12 to S92. If a fracture is not indicated as opened or closed, it should be coded as closed. And if a fracture is not indicated as displaced or not displaced, it should be coded as if it's displaced. Coding for burns and corrosions. Same principles for multiple coding applies to burns. You code each burn separately unless there is a combination code that would include both of those. And there are a lot of combination codes in the burn section. So again, we want to make sure we read them carefully. Because burns are coded by site and degree and by extent of body surface involvement, all burn cases should have at least 2 codes and possibly a third if it is considered infected. ICD-10 makes a distinction between burns and corrosions. Burn codes are used for the following: thermal burns that are caused by a heat source, such as fire or an appliance, burns resulting from electricity, and burns resulting from radiations. Corrosions are burns caused by chemicals. The guidelines for either are the same though. Current burns are classified by depth, extent, and burn agent. So the depth is first, second, or third degree. So first degree is erythema. Second degree, we have blistering. And your third degree would be full thickness involvement. Burns of your eyes and internal organs are classified by site, but not by degree because you can't see
them. If it's an internal organ, you can't tell what depth it is. Coding for drug toxicity. Chapter 21 has codes for drug toxicity, poisoning, reaction to improper use of a medication, adverse effect, unfavorable side effect occurring through a medication correctly prescribed and properly administered, underdosing, patient takes less of a medication than is prescribed, or a toxic effect, patient ingests or comes in contact with a toxic substance. There are codes in the T36 to T65 section that are combination code that include the substance taken and the intent. When you are coding, do not code directly from the table of drugs and chemicals, and I mentioned that earlier. There may be one code, but you've got to go to that tabular and read the description to make sure it matches. Coding for external causes of morbidity. In ICD-9, they were E codes. In ICD-10, there's Chapter 20, which is external causes of morbidity, V00 to Y99. They're mostly for data for research on injuries and injury prevention strategies. They capture how the injury or health condition happened, possibly the intent, and the activity and where the patient was when it happened. Place of occurrence guidelines. Y92, place of occurrence of the external cause. These are secondary codes. They are used after the code to identify the injury as the location or where the patient was at the time of the injury. Place of occurrence code is only used once at the initial encounter for treatment. Activity code, Y93. That tells you what the patient was doing at the time of the injury. Only one code from category Y93 should be recorded in the patient's health record. You should use an activity code in conjunction with a place of occurrence code. Do not assign unspecified activity if the activity is not stated. So, for example, you are coding a closed ankle fracture that occurred while the patient was playing soccer in a public park. So first you're going to have the code for the fracture, and it's coded as displaced because the description doesn't specify. And remember, if it doesn't specify displaced or non-displaced, you code it as if it's displaced. And then they were playing soccer, so we have soccer, and they were on the soccer field. If the report did not state an activity, remember, you do not use unspecified activity. But this one was done in a public park, so there is a code Y92.830 for a park. There's codes for occurring in a camper, nursing home, place of residence, by room in your place of residence, so like in the bathroom, in the bedroom, all different kinds. It just provides the insurance company, again, if we're using a code that it happened at school, then maybe it's possible the school's insurance should be paying for that instead of the patient's health insurance. And again, for tracking and statistical purposes. Coding for health status and contact with health services, Z00 to Z99. These replace our old V codes. Contact, exposure, inoculations, vaccinations, health status, history of screening, observation, follow-up care, anything like that. That is coding for health status. Again, you don't need to remember what chapters are what. When you look it up alphabetically, if it pertained to a code out of chapter 21, then your tabular list is going to lead you to that section. How do we maximize third-party reimbursement? Again, we want to use the highest level of specificity because if we do not, we are not going to get the appropriate reimbursement for our provider. We want to do that by using the current
manual for ICD-10. Stay informed of changes, revisions, and additions. So meaning we do not want to use outdated codes because obviously the claims will be denied and that's costing us to resubmit them again and be delayed in payment. Code accurately from documented information, making sure appropriate code or codes are assigned. Be sure the diagnosis corresponds to symptoms and treatments. Many codes are specific to age and gender. Review data to make sure no digits have been transposed. Know your insurance carrier's rules and requirements. Some insurance carriers may require certain things, and it's just nice that we know that. Some carriers don't want or don't care if we put the activity in the place of occurrence code for an injury. My rule of thumb is if you're putting it for some, you put it for all. If they do not want it on there, they can ignore it. Incomplete or inaccurate codes can result in delay or denial. So again, we want to make sure we are submitting that properly. Providers and accurate coding. The documentation in your health record is going to help coders select the code to the highest specificity. Therefore, we may need to train our providers about the documentation process. They know how to document, but like when ICD-10 came about, we had to let our providers know that in order for us to now select fracture codes, we had to know what type of fracture it was and what stage they were at. Is it the initial? Is it a subsequent? Is it healing? Is it non-healing? Is it not aligned properly? Without that information, they were going to get the charts back and they were not going to be billed until we had that information. So the medical assistant should stress to providers the value of detailed documentation and how that helps to improve ICD-10 code assignment. Staff meetings to review third-party payment requirements should be held regularly by the medical billing supervisor. Medical assistant should be respectful to the healthcare provider when third-party requirements compel more effort on their part. So understanding and patient attitude toward the healthcare provider go a long way in building that trusting relationship. So there are some ethical standards of medical coding. So meaning when you look at coding, you look at it from all sides, the money side, the start to finish. Stand your ground, meaning you code from what is documented, don't add things. If some coders are not following ethical coding standards, speak up, say something, because that can affect the practice. So in closing, diagnostic coding in ICD-10, there's almost 70,000 codes. So there are steps to follow to help us get the most accurate ICD-10 code. And again, I mentioned there's also software that can be used. Detailed documentation in the health record is needed for accurate coding and maximum reimbursement. You can best communicate with your healthcare professionals, again, about showing them what is needed in that documentation in order to select the codes. And again, when in doubt, we need to ask our provider for clarification. My doctors don't mind being asked because they know if I'm not provided the correct information, it's not going to be able to be billed, which means they're not going to get that income. Most most patients know very little about coding, so it's hard for them to understand the coding system. It's like a foreign language, and I tell my coders it's a foreign language when you learn to do it as well. So understanding the insurance billing processes and how to look up codes and definitions definitely will help. Using the coding system allows providers to express simplicity or complexity of treatment, and again allows maximum reimbursement for the provider. So they can say exactly what happened during that treatment.
And we as coders do not exaggerate those codes to get more reimbursement for our providers. So that is it for chapter 14. So again, that was the diagnostic coding side of it. Next week for the MA class, we will be doing the procedural coding. All right. How are you, Kim?
I'm good. How are you?
Good. It's kind of weird to do a class where I'm not talking to anybody. It was like,
that must have been interesting, huh?
All right.
The good thing is you didn't have any questions.
I know, that's true. It's a good thing because that chapter, when I first looked at it, I was like, there's no way I will get through that entire chapter tonight. But like you said, with no questions, it did make it a little easier to get through it.
No questions, no issues.
Yep. So I think I was trying to remember. Last week, did you watch the lecture online?
Because it took me a while to find where my part of it starts.
Yep.
So I got maybe about halfway. So I didn't go all the way through. But
Okay.
I am, as far as where I'm at, I finished lesson 8, all of my tests and all of the coursework. So I'm working on 9 now.
Okay. And that's what last week we did chapter 9, the receiving payments and going to the insurance commissioner if needed. So
Okay.
Tonight is office and insurance strategies, chapter 10, because we did not even start on chapter 10. I know your syllabus says last week we were supposed to do both 9 and 10, but that did not happen. So we'll start with 10. If we get into 11, great. 10's a fairly long chapter. If we don't get into 11, we'll just start with 11 next week.
We do have class next week?
As far as I know, yes. The woman is double checking on it. She said that because of the snow days, they believe that the school is going to hold classes right up through. It may affect my Thursday class, but it won't affect you guys. So we'll have class next week, and then the following week, which is the week of Christmas, we will have completely off. And then the kids go back to school January 2nd. So we would have school on January 3rd.
Okay, so we'll just miss the 1 week.
Just the 1 week.
Okay.
Yep.
Excellent.
And then, if I figured correctly, pending snowstorms, hopefully we won't have any, we should be done before February vacation, depending on when that falls. So hopefully we won't have another vacation in between there.
Okay.
All right, so office and insurance collection strategies. So we're going to talk about cash flow, accounts receivable, procedures in collecting accurate patient information, policies for managing patient accounts and collections, having guidelines for missed appointments, fee adjustments, talking about patients, about fees, payment options, aging accounts, dunning messages we'll talk about. We'll go into credit laws, collection laws, how to communicate collections, written or oral, making phone calls, that type of thing. So, the cash flow cycle is obviously most important, and the process has become increasingly complex. We do have the availability of credit or credit cards now that a lot of offices use, which is nice because it allows you to get your money up front and the patients worry about dealing with it later. Depending on the cost of processing those fees for offices, some offices may only take Visa or MasterCard. They may not take Discover or American Express. Some offices allow that care credit, which is just like a regular credit card, except you you need the care credit system to process it. So we have a lot of patients ask in our area, do you take care credit? And we have our own credit card system. So in order for us to use care credit, we need another system for that. And because we have like 3 different locations where they could pay, to have 3 additional systems is not cost effective for us. So they've deemed not to use it at this point. But a large percentage of reimbursement to physicians is generated from third-party payers, which are your insurance carriers. So the physician, the practice administrator responsible for financial affairs, and patients must understand insurance contracts regarding reimbursement, authorization, medical services not covered, what the patient responsibility is, and how the offices get reimbursed. And unfortunately, even though we say that about the patients knowing about authorizations and services being covered, they still think if their primary care tells them they need to have a test done, that it's going to be covered. Or in our case, we do the osteoarthritis, so we do the medication like Synvisc into the joints. That's not covered by a lot of insurances. And even though we tell the patients they're going to be responsible for it out of their pocket, when they get the bill for it, the doctor said I needed to have it done, therefore it should be covered. A lot of them just do not understand. So stressing that to the patients is one of the things we have to try to do. The accounts receivable is your unpaid balances from patients and insurance carriers for services that have been rendered. And we want to make sure that our AR is addressed timely. Can be probably, depending on the office, sometimes they have a person that addresses it weekly. It could be monthly. But your cash flow is the availability of actual cash in the medical practice. So when charges are collected at the time of service, the AR would be 0. So you typically want to have today's date of service be paid for in 60 days. That's both the insurance company and the patient responsibility. Now, depending on the patient responsibility portion, 60 days may not be reasonable if they need to go on a payment plan. But that's the ideal goal to get the AR where you want it. Healthcare expenses have increased and exceed the expenses the patient pays for. So therefore, that's one of the reasons that the 60 days may not be doable. Public seems to have the attitude that it is a right rather than a privilege to receive the best possible care. So therefore, they don't always pay properly or promptly. Legal proceedings can delay payment of medical expenses. Third-party payers sometimes don't pay promptly. They will deny claims just to see if we are paying attention, to follow up on them and question why they're not being paid. And we've had Medicare representatives do speeches for us, and they said that there will be times when they'll be processing claims and they'll be told, deny the next 10 claims. There's no reason, they just deny them. So they're looking to see if whoever is handling those denials when they come in are truly looking into them and finding out why they were denied.
Now, does that go against the current laws in place with regard to, is that a loophole? Because I know aren't they required, like third-party payers, all of them, aren't they required in so many days if they are in contract with you? Aren't they required to pay the claim or deny the claim or whatever within so many days?
Yes, they're required to process the claim. So they can deny
process
the claim.
Doesn't mean, okay.
Yeah, so if they deny the claim, what they're looking for is like if I get a denied claim and it says, let's say they use the denial code, not a covered service, and they have it written off, which means I can't even bill the patient. I'm going to question that, because if it wasn't a covered service,
when my staff called to get that surgery authorized, they should have been told it wasn't a covered service. So I'm not just going to write that amount off and let it go. What they're looking for is, if I'm going to readdress it, fix it, or whatever, or call them on it, then they've got to pay it. There are some offices out there that, because they're so big in volume, they don't have the personnel to address denied claims. So some of those amounts just get written off. So then that insurance company knows that every so often they can deny claims and it's not going to get looked into.
And that's huge. Like, I noticed that a lot in the practice that I'm in right now, because it's a really small office. It's one doctor, it's 1.5 staff, it's one biller. Mm-hmm. So, I mean, that one person needs to know every single insurance, everything. And, you know, they all of a sudden, you know, I'll get all of this backflow of, you need to call this patient and confirm their insurance, whatnot, because all of a sudden they just decided, oh, we're just going to deny a whole bunch of claims, which made no sense, because the insurance, they had been covered by that exact same insurance policy. It's like, they're like, we don't have time to know every little nook and cranny of every little thing like a hospital would, where there's 5 billers and 2 of them are responsible for that insurance, so they know it.
Right, but that's a problem in a small office like that, because that's obviously going to affect your cash flow.
Absolutely affecting cash flow and accounts receivable, yeah.
Yeah. So if all of that, you know, like our computer system is able to at least check patient eligibility with the insurance before we submit a claim. So before I submit a claim, if I do an eligibility check and it tells me the member's not eligible, then at least I can check the insurance side of it as far as eligibility goes before I get it out the door. But if it's denied for, you know, like not covered service, or maybe a coverage determination, maybe that code's not covered under that particular thing.
My favorite one is, the referral came from a doctor that is not listed on the patient's card.
Yep.
And then you call the patient, and the patient's like, I've had the same doctor for the last 20 years.
But they've never had a chance.
When my insurance card came and I saw that it was not my doctor, I called. That was 6 months ago. So they did not change it.
Right.
So it's almost like they're trying to find ways so that they don't have to pay out a claim. And it's getting very frustrating.
Yep, it is. And, you know, we've got to have a way to track it, because the longer we let them go, you know, not address those unpaid ones, it's going to definitely affect our AR, and we're going to run into issues. But you're right. I mean, if you've got I've got 3 physicians and 12 physical therapists, and I'm the only biller in the office.
So, I mean, and you take almost all insurances, correct?
Yeah. So I do everything from charge entry to collections to posting to follow up, everything.
Now, how do you handle, like, knowing, because you obviously have to know so much about all of these different insurances. I mean, do you have, like, individual binders for, like, you know, like an Anthem binder, a Harvard Pilgrim, and you just, like, put notes everywhere?
Yep.
Okay.
Yep.
Because I'm trying to figure out how to do that, because I know that I'll at least be at this practice for a little bit, and some of what I do, like, I'm not the biller, but I'm handling, because I'm going through this course, I'm getting a lot more questions from the biller.
Yeah.
What, you know, oh, so you know this. Okay, well, why don't you make this call to the insurance company, doing some of the grunt work that just one person doesn't have time to do. So I'm like trying to figure out, okay, how do I organize this so that I know what I need to know?
Yeah, the binders are usually the easiest way, and then you can divide it by, you know, sections, or what I tend to do is I'll put, like, if there's, like, their newsletters with policies or changes, if it pertains to me,
then I'll put it like maybe in the front of the binder. So the most recent is always in front. But in each of the binders, I'll have like their appeal forms and their appeal process or their reconsideration process. Make sure I've got contact information. If they have websites where you can go on and check the claims or address the claims online, make sure that the login information and the websites are all there. But just buy the binders, and I guess because I'm the only one doing it, it's just one of those things that unless something changes, my brain just, I don't know, it stores it somewhere, and then when Anthem comes up, it's like, oh, that's what that is, you know? But yeah, binders are the easiest way to do it.
Okay. Yeah, right now I have a folder because for the front staff, what we figured out was the insurance cards.
Yep.
So we were getting insurance cards and, finding the payer ID, and some insurance cards will have the payer ID on them, some of them won't.
Right.
So looking, making sure that each person when they're coming in, that their insurance card is put in correctly in the system.
Yep.
And then we verify, check it. And then there are some, like Martin's point, I don't have access to do an eligibility check. Like I can't do a verified check. So, once a year, I'll do a quick call, push in the button, say, oh, yes, this person is eligible as of this date. Perfect, okay. Make sure that they're current.
Right.
And check their cards, because I found that led to less kickback from the billing department, because we were constantly getting notes. Check this person's insurance, check this in, this isn't correct, and what is this? It's like, okay, figured it out. So some of them we didn't know. I had no idea. I'm like, okay, we had 2 Harvard Pilgrims in the system. Did not know which was which.
Right.
Yeah. So I have pictures of the cards. We whited out the patient's information, and it's like, okay, this card gets put under this payer ID, so that every time we get a card, we're not sure, pull it out. I had to make a list for my coworker of all the Medicare Advantage plans.
Oh, yeah.
Because she was like logging in some of them as something else, because she didn't know it was a Medicare Advantage plan.
Yeah.
And she didn't know that we needed to do something different with it. So I'm like, okay, here's a list of them. Here's the most common
and you're right,
ones.
that's half the battle right there. Because if you don't get it right there, they may not go to the right place. They could be delayed in getting processed, whatever it happens to be.
Yeah.
Yep. So the best way to keep AR down is what you just talked about, verifying insurance benefits if possible, collecting the copays. If you know they have a copay, collect it up front. Then that's one less thing that you have to send them a bill for. Now, a lot of times they'll have an office visit and maybe x-rays. They've paid the copay when they come in, but then the x-ray goes through and the x-ray is applicable to deductible. So yes, they're going to get another bill for the x-rays, but if you collect that copay up front that you know is due, then that obviously you're going to keep the AR going from there as well. Some offices will collect the co-insurance up front as well if it's like 20%. I find that a little harder for us, for my front staff, because they don't know what the allowed amounts are. So for them to figure 20%, they'd have to figure it on what we charge, and obviously that's going to be more than what the allowed amount is, so we'd always end up refunding patients. So I said, no, you only collect what we know they owe, such as a copay. If it's a co-insurance or deductible, we're going to let it go through, and then we will bill the patient. It was just easier all the way around for that.
Okay.
On 324, you can see the flow chart for the billing. So again, they schedule the appointment, patient's registered, they have their visit, input patient registration into computer, the encounter form, post copay and deductible, patient encounter into database, transmit the insurance claim to the third party payer, prepare, send monthly statements, delayed billing if it's pregnancy or multiple surgeries, third-party payers, explanation of benefits, post-payments from patients, follow-up, collect delinquent, and then produce practice management reports. So your collection ratio is the relationship of money owed to the physician and the amount of money collected on the physician's AR. So obviously a good collection rate would be 100%. That's what would be desirable. But it can be calculated on a month-to-month basis. And most of your practice management systems will give them that percentage so that you know month to month what you are collecting, so that you know if you're doing the appropriate amount of follow-up or not. Because as you know, if it's one person, I don't always get to my AR once a month like I should. And that's bad because I know it needs to be addressed. But if I'm entering over 150 charges in one day, 5 days a week, I can't always get to the other things that need to be done.
Okay.
So while most Americans know that health insurance is right, a lot of them don't know how it actually works. So that's your benefits, including how many appointments are allowed for, especially with our Medicare patients for physical therapy. Medicare patients do not realize that they have a limit on how many visits they can have per year. It's not per problem. It's just per year. And,
Really?
And it's not per provider either. So if we have a Medicare patient that, let's say they, I don't know why, but let's say they lived up north and they had physical therapy up there, and let's say they had 12 visits and then they moved or they're down here visiting and they set up physical therapy with us. Well, the visits that they had up there count towards their maximum number of visits. So some patients that hop from therapy to therapy, different providers, they will go to one and they'll have their 24 visits and they're up, so they think they can go to another provider and get another 24. That's not the case. So understanding the benefits is a big thing. Their out-of-pocket expense after the insurance paid, what are they going to be liable for? Medications, medical equipment. Different between emergency and urgent care costs. The Affordable Care Act 2013 allowed more people to have health insurance. It allowed 100% coverage for preventative care, eliminated pre-existing conditions, discount medications. It also provided subsidized health insurance for a low income and allowed the kids, they're not kids, young adults, up to the age of 26 to remain on their parents' insurance unless they got insurance of their own prior to that. A new patient information packet should be provided to the patient on their initial visit or sent to them in the mail. A lot of that, I don't think a lot of offices do it anymore. Offices used to send out like a little brochure about their practice and their policies about billing and stuff like that, so that the patients would understand. We do it with our self-pay patients. If they're scheduling a self-pay patient, after they're scheduled, they transfer them to billing, and I let them know how the self-pay process works, so that when they come in the door, they're not blown away that the specialist visit might be $300 that day, and they're expected to make a payment that day, or if they pay that day in full, they can get a cash discount. So being able to provide that information in a packet sometimes is nice. No substitution for good information, so getting that initial information, the correct insurance, spelling of the name, whatever it happens to be, that's where it needs to be done so that you or I don't have to do all that grunt work after and follow up on all those. Learn as much as possible about the patient before the services are provided. Mostly that's going to be on the health information packet that is sent to them for the provider. But some indication that is going to delay payment, incomplete information on the registration form because we're not going to have the information to send. Sometimes the information that they put on the registration form might be okay for us to bill originally, but then when we go to send it to collection because they've not paid the bill, we may not have enough information to send it to collection, such as telephone number or social security number or something like that. Multiple changes of residence. If somebody is filling out their paperwork and they give us an address of general delivery and they're self-pay, then my front knows that they should be asking for the money up front, because we have found that those patients will send it to general delivery and it's not accepted because they've already moved on. So they're those transient patients and then you can't track them down. Questionable employment record, no telephone numbers, post office boxes with no street addresses. They give you the address of a motel. That's all questionable. Incomplete insurance or no insurance, and no referral or incorrect primary care, for example. So on page 326, this is just a confirmation letter to a new patient, telling them when their appointment is, confirming the date and time, the approximate fee, payment options if necessary, about canceling their appointments, and that there is a fee for a missed appointment. Having them aware of that so that they can't come back after they've no-showed twice and you're billing them a fee and they want to call and schedule. Until you pay that missed fee, you cannot be scheduled. Well, where was that? That was in the original paperwork that we gave you and you signed it. So making sure that all that information is laid right out for them. Employers change health plans frequently. So I can't stress the importance to my front staff enough to make sure they get current copies of cards. The other day, we've seen a patient, since October, we've seen them 3 times. So I let it ride the first 2 times. I didn't let it ride the last time. The last card that was scanned in the computer was from 2012. So why are they not getting an updated card? Well, the numbers didn't change. I don't care if the numbers didn't change. What if the electronic payer changed? You know, that number. What if the address changed? So, again, making sure every time they come in, if you look at it and it's the same one you got in there, great. But at least making sure that it is being checked.
Okay.
Most practices operate with a set of fees that are uniform to all patients in the practice. They are set by the physician. And most of them are either, the fees are based, they look at what Medicare reimburses, or they'll look at what the workers' comp reimbursement is and set the fees according to that. So a fee schedule is a listing of accepted charges or established allowances for medical procedures. Missed appointments, again, these are expensive for providers, so patients need to be informed about keeping appointments. I mean, we do reminder calls 2 days ahead of time. So if you know 2 days ahead that you're not going to be able to make it, let us know. And again, be aware of the fees so that when we charge them for missed or canceled appointments, they are not surprised. Discounted fees. A physician may choose to discount his or her fee for various reasons, but this is typically not recommended, and it can be illegal in some circumstances. So a discount is a reduction of the normal fee. When a physician offers a discount, it must apply to the total bill, not just the portion that is paid by the patient, which is their co-insurance or their co-amount. So they are giving a discount to both the patient and the insurance company this way, not just the patient. This can reduce the physician's payment because the insurance company, it triggers a reduction in the allowable for the provider. All discounts must be electronically posted to the patient's accounting record, and any financial reasons or special circumstances need to be documented. So typically, they tell you not to do this, to not have your providers do that, just because you've got to make sure legally that you're not going to run into issues. Cash discounts can be offered to patients who pay the entire fee in cash at the time of service, but that policy needs to be in your policy and procedure manual and posted in your office, and it needs to be offered to every active person. And it tells you to research the state laws about cash discounts, because people that have health insurance will come in, and if they have a $50,000 deductible, they'll ask if they can pay on the date of service so that they can get it cheaper. Maine state law says that legally, if they have health insurance, you cannot offer them a cash discount. Your cash discount only applies to self-pay patients.
Okay.
If they have no health insurance, because if you're offering a self-pay discount to somebody that has health insurance, when they sign that health insurance, they agreed to pay their deductible and their co-insurance or whatever. So if you're giving them a discount, they're not paying that full amount of their deductible and co-insurance.
Okay, what if you have a patient that comes in to the office, they call, schedule an appointment, very first question you ask when someone calls and says, I've never seen the doc before, I want to make an appointment, and you ask that question, what do you have for insurance? They say they're self-pay. They come in, they say, well, I know my insurance isn't going to cover podiatry or ophthalmology, whatever it is.
Yeah.
I know it's not going to, that I'm going to be a self-pay patient. Well, they have insurance, but they can't or are not going to. Do we need to have do you need to have something in the billing policy? Should there be a separate statement that they need to sign that they're saying that they are declaring themselves for this practice to be self-pay, and then you can do that self-pay discount?
Typically what we do is if they come in and they tell us they know this is a non-covered service with their insurance, we tell them that, okay, it may be a non-covered service, but in case it is covered and it needs to go towards your deductible or whatever, we have to legally submit it to them because you have health insurance. It may be a non-covered benefit, in which case we have them sign an ABN,
right,
Advanced Beneficiary Notice. Then if it comes back from the insurance and it says it's non-covered and the member is completely liable for the entire cost, then you can offer them the discount. Because it's gone through the insurance, they've said it's non-covered, and now the member's going to be liable for the full amount. So now you know it's truly non-covered with his insurance. So now you could send them the bill or call and say, it's gone through your insurance. If indeed for the self-pay discount, it would be. But we submit it through the insurance because they might have an office visit, and the office visit is covered under their health plan, but maybe the prolotherapy that they have is not because it's investigational. We still submit it, but then they sign the ABN, and when it comes back, then we'll give them the cash discount on the whatever was not covered. But we always submit it first because we were told by our accountants legally, if they have insurance, we should be submitting it.
If they have an insurance card, so if they have health insurance, we need to submit.
Yep, you can check with, if your office has an attorney or counsel, you can check with them. But we ran it, our doctor wanted to make sure that we were following, correct protocol, and we ran it by the
You kind of have to.
Yeah, and the attorney said, now if they outright tell you they have no health insurance and they're hiding it from you and you have no way of knowing that they have it, that's one thing. But if they're telling you they don't want it submitted to their insurance company because it's non-covered, right there they're telling you they have insurance, so we should be billing it. Because
so if they indicate that they have insurance, then it needs to go through insurance. But if they just say, nope, I'm a self-pay,
right, and
all the way through the entire thing, they're saying they're self-pay, and we bill the patient, we do the self-pay discount, and then they turn around and go behind our backs and try to submit it to their insurance, then that's
not your fault.
That's not us.
They didn't tell you.
Okay.
Yep.
All right.
Nope. Just did cash discount. Financial hardships. That's going to truly depend, with giving discounts. It's discriminatory if you don't offer it to all patients. And the financial hardship, depending on your office, if you're a private practice, you're not privy to those extra funds that are available to bigger entities such as facilities that get, not financial aid, but federal grants or anything like that. So for financial hardships, there are forms online that you can get. You can kind of gear it towards your practice, but that has them fill out like certain income requirements. And depending on where their income falls, if it falls within certain ranges, then if it's a policy of your practice, you can then discount or use like a sliding fee schedule. But again, they've got to prove that financial hardship. They just can't tell you that they are. And we have patients that will apply to the hospitals, and they'll get completely free care at the hospitals. And then they'll question why that hospital free care doesn't carry over to our provider who did the procedure there, but we're a private practice and we don't get those funds that they get. So if they can prove the financial hardship, then we may be able to help, but they've got to be able to prove that hardship.
Okay.
Write-offs or courtesy adjustments is a debt that has been determined to be uncollectible and taken off the books. It's lost income, but may not be claimed as a loss for tax purposes. Insurance specialists should obtain financial information on all patients who request a write-off. You don't just write something off because a patient calls and tells you that they only get their, their retirement check and they have this and this and this to pay, and if they pay you, they're not going to be able to get groceries. They need to submit the proof, documentation, and then any write-off goes to the provider or whoever is in charge of taking care of that. No write-off is done without getting the physician's authorization. A write-off on page 329 is possible in 3 circumstances. The first is, as stated in the preceding discussion, when they prove financial hardship. The second is when it would cost more to bill balance than what is owed. So if the patient owes you 24 cents and it's going to cost you 50 cents to send them a letter, postage, it's not worth generating that. So that can be considered a small balance write-off.
Okay.
This type of write-off is a small balance. The third situation is when the provider has made a good faith effort to collect the balance with no result. That can be written off, or it can be sent to collections. Most offices, they're going to set an amount. So if after 4 billing cycles, you've billed them for $40 and they've not paid you anything, that's probably going to be written off as bad debt. Versus somebody that owes you $200, you're probably going to send to collection to try to get that. But depending on what the collection agency charges, $40 may not be worth sending to the collection agency if they keep 50% of it, because then you're only making $20.
Okay.
So, professional courtesy, no. The Code of Medical Ethics, way back long time ago, and the AMA, they state that professional courtesy should not be really done. Professional courtesy is a discount or an exemption from charges that may be given to certain people at the discretion of the physician. There was the CMS in 2007 identified proper ways to identify or to offer professional courtesy, offered to all physicians on the medical staff or local community. The healthcare items and services provided are of a type routinely provided by the entity. The entity's professional courtesy policy is written and approved in advance by the governing body. Professional courtesy is not offered to a physician or immediate family who is federal health care unless there's been good faith showing financial need. Professional courtesy involves any whole or partially reduction of any co-insurance obligation, and the arrangement does not violate the anti-kickback. So our rule of thumb is not to offer professional courtesies, period, because if another provider is seeing you, they have health insurance, they should be billed. Now, if they don't want to pay their copay because they don't think they should have to because they're a provider, then you do the normal. You bill them the 3 cycles that you normally would, and if they ignore your bill and they don't pay it, when the time comes, you've showed the good faith effort that you've done your process and you've billed them and they've not paid. So if it's that $20 copay, then it gets written off, or bad debt, or what have you. But to just out front do it, if you offer them the professional courtesy on something that's been applied to their deductible, their co-insurance, and or their copay, one of 2 things can happen. If you get audited and they continually see that this is a thing, that it's being offered to Joe Smith, who's his neighbor, and Mary, who's the wife of your employee, what can happen is not only can the provider lose their contract with that insurance carrier, but if I was the patient that he let me not pay my copay, I can lose my coverage with the insurance company. Because when I take out my policy, I'm agreeing to pay my copays and my deductibles. I'm not paying my copays or deductibles if they're getting waived.
Right. Okay.
Obviously, that's only going to happen if you get audited. But what happens if somebody knows you're doing it and they find out you're giving discounts to the whole neighborhood? They could call the insurance companies and whistleblow on you, and then you're going to run into issues. So I tell my provider, look, I know you want to do right by your neighbors or a fellow provider, a fellow physician, but rather than get into issues, we are going to bill them. If they don't pay the bill, then fine. We proved that we've sent it, and then we're good. And you can write it off then. But we're not going to just write it off up front. So some providers will do it because that's how it was years ago. You could. And then as the laws progressed, there's more and more that you can run into issues with. So they should have policies on professional courtesy to make sure they don't violate contractual terms in the insurance's contract. On page 330, the copay waiver, again, that's another way to reduce the cost of medical care. But again, it's not recommended because that copay is part of what their allowable is to pay you. So if your visit was $200 and the insurance company allows $150, that copay is part of that $150. So if you're writing it off, you're not getting your full reimbursement. So again, another reason why that is not recommended. And again, waiving copays can violate the contract between the patient and their carrier as well. No charge is waiving the entire fee for professional care. This is permitted as long as it's not part of a fraudulent scheme and it's offered to all patients. All no-charge visits must be fully documented in the clinical portion of the patient's medical record and their account. As a way of trying to satisfy a deductible, a physician or insurance billing specialist cannot assess a fee for services that an insurance company or third-party payer does not cover. Another instance when no charge occurs on a patient account is when follow-up visits are posted after a patient undergoes surgery, which is considered the global period or the post-operative period. There's the 99024 code that's used for no charge for 90 days after that surgery.
And we're not supposed to collect the copay on those visits, correct?
That
If
is
it's
correct.
a no-charge visit, it's part of the global period.
Yep, absolutely. Yep. Precautions should be taken before reducing the fee of a patient who dies. Yes, they passed on, but if they have a bill, it still needs to get sent to the family in case there's an estate, and the estate would handle the balance of that bill. If there's no estate, then we just ask for documentation, and so that we can in turn legally support why we just wrote that amount off. Especially, I mean, if it's, under $50, it may not be a big thing, but if we're writing off thousands of dollars and they had an estate that would have paid it, at least we are going to be covered. Discussing fees. Yes, it's difficult to ask patients for money and talk about finances, but a lot of medical practices, if you're going to have a hard time collecting money, it's easier to talk to them up front about it. Be courteous at all times, yet firm, business-like approach. Never badger or intimidate a patient into paying. Merely state the payment policy and educate them. Inform the patient of their financial responsibility. Verify their copay listed on their insurance card. Collect before they're seen or when they check out, depending on how your office is set up. Make it easier for the patient to pay rather than leave without making payment. Do not give the patient an option by asking if he or she would like to pay now or have a bill sent. You just ask for their copay. Motivate them to pay by appealing to his or her honesty, integrity, and pride. And again, communicating. The office visit is $62. How would you like to pay for that today? Or would you like to pay by cash, check, or credit card? Your copay for today is $20. Will that be cash, credit card, or check? Your insurance policy shows a $100 deductible. That has not been met. You must pay the full amount today. This is an office that requests that the deductible be paid up front. Mrs. Merriweather, I must collect $477 today for your vitamin B injection. The injection is not covered by your insurance policy. So if your office is providing a service that you know is not covered, then again, they sign that ABN and you collect that up front. We look forward to seeing you. The consultation fee will be about $150. Payment is expected at the time of service. Again, that's why I talk to the self-pay patients ahead of time, so that they know that if they pay that day, they get that 40% cash discount, or if they don't, they're going to be billed the full amount and they have to make a payment that day. I also do it for all our surgery patients. I check their benefits so that they know what to expect out of their pocket, so that we know what we can set up as far as payments once surgery is done. Again, collecting copays and other amounts at the time of service is strongly recommended. That helps alleviate billing, sending the patient a bill for a statement for a $5 or a $10 copay. One-on-one communication, best way to motivate a debtor. Each patient's account balance should be reviewed before his or her appointments. So maybe the week before, when I check referrals, I will also check their balances. And if they have a large balance and I go in the system and I see they're not on a payment plan, I will call them ahead of time and let them know that there is some sort of payment due that day, and we can set them up on a payment plan if they're not able to pay in full, rather than have the habitual person who never pays their copay when they come in, have them come in again to not pay their copay, yet they got a $400 balance because they keep racking up their copays. So if there's a way for that to happen, it's good to look at those large balances ahead of time. To do effective pre-appointment collection counseling, the patients should be taken to a quiet area. Obviously, you don't want to do it out in the waiting room, but you understand, let's work something out, give them the minimal payment plan if that's an option for them, let them know what the policies are, everything like that. Face-to-face interviews better than a telephone because you can get them to sign an agreement. So if you're setting up a payment plan with them in person, you have a form that says they agree to pay $25 a month until paid in full. It can also have a clause that says if monthly payment is not made, account may be sent to collection. That way they know that if they miss that payment, you can send that account to collection without checking with them first, because they're aware that that can be done. So again, having them be able to sign something is much better than doing it over the phone. If I do it over the phone, I always document in the computer that what the patient has agreed to over the phone so that it's in there.
In counter forms, we talked about those. Those are the multi-purpose billing forms. Again, many names, fee slips, billing forms, encounter forms, super bills, whatever it happens to be. They can be given to patients to bill to their insurance companies. They inform the patients of current charges and outstanding balances, and they can be used as a receipt for payment. Probably not going to be used for the patient to bill the insurance companies, because I think a lot of the providers do the common courtesy and bill for the patients. Patients' excuses for non-payment, I've heard them all. Things come up, and I understand that. I mean, it happens to me as well. But let's work with them to get those payments coming in. Credit cards and debit cards. That's an easy way to do it by accepting credit cards and debit cards. The patient's paying you up front, and then they can pay the credit card monthly if they opt to. It's easier to set them up on a payment plan with us because we don't charge interest or finance. Some offices do, but you've got to be able to calculate that interest or finance if you're going to charge the patients. If you accept credit and debit cards, you're lowering your risk of embezzlement for the cash and or checks that you may get for those co-payments or payments on accounts. Fewer trips to the banks for deposits, fewer concerns about check fraud, and it's convenient for the patients. So if you're taking a check from a patient, we don't have any way of knowing if they really have that money in their account. So that check could bounce, and then you've got that bounce check fee as well. Credit card payment is an option, again, allowing the patient to pay you and then pay the credit card. Display a credit card acceptance sign if you do accept credit cards and what kinds you accept. An insignia or message on their statement that they can pay by credit card and how to do that. Include the credit card policy in the brochure or the welcome letter if you send that out. Have staff members verbalize that that's an option. So again, would you like to pay cash, check, or credit card? Verifying credit cards. Making sure that it's not been canceled or stolen. Typically, if you're taking a credit card from a patient, it should have their name on it, and then you checking the expiration date. And when you run that credit card, if it's not a valid credit card, it's not going to go through your system. Ours, we have to key in. So if we key it in and it's not a valid card, it flashes and says, this card is not acceptable, or it will say this ID number is, or credit card number is now invalid. Patient has new card, or member has new card. So you don't have to validate using a phone call or anything like that. But this is an example of a payment plan letter on 333. So if you were sitting in the office talking to them, the cash price of the treatment, a down payment if required, the amount covered by the insurance or an estimated amount, what the unpaid balance is going to be, if you charge interest or finance, the unpaid amount, and then what the monthly payment is, when the first payment is due, and then they sign it, and or the physician or your billing supervisor. And that would probably be kept in like a little tickler file, so that every month, again, if that payment didn't come in, then it says the patient has the right to pay without penalty. This one does not say if not paid would go to collection, but you could also put that in there. If monthly payment broken, account may be sent to collection or something. But that's a nice letter and a good way to do it, and you keep a copy and you provide the patient a copy. And that way every month when they get their bill, it's going to have what's fully due, but then it will have, ours says what is monthly due. So if they're on a payment plan, it will say now due $100, but then on the last page it gives their full balance. So they always know what's still left to pay. Again, verifying credit card holders, making sure that their name is on there. You could ask for photo ID if you wanted.
match the name on the card with ID or license. Look on the back of the card for the word void. This is an alert that the card has been heated, which is a method used to forge a signature. Check the hot list for problem cards and compare signatures. On 334, you've seen them before, but that's an encounter form. So again, here it's got patient information, account number up at the top, the insurance information, and then it's got the CPT code. So the provider has checked what level visit and circled the code. He's done an EKG, and then down on the bottom is the diagnosis code. So if you do up your own encounter form, you gear your encounter form towards your practice. So if there are CPT codes that you don't perform, you don't need them on your super bill. You put your codes that you most likely use in the office. You'll see there's, this one doesn't. This says doctor's note, but ours had a spot for other CPT codes. So if there was one that he used, like once a year, he could pencil that code in. We didn't need to add it because it wasn't used enough. And then down at the bottom, he's checked off what the diagnosis code is. In this case, there's just one checked off. So as long as that code supports the office visit and the EKG, great. If we needed more codes, let's say that chest pain was not a reason for a particular blood test, then we may need to go to the doctor or the documentation to look for more diagnosis codes. And then he signed it, and this one has a note on the bottom. Please remember, payment is your obligation regardless of insurance or other third-party involvement. And that's a big one with the third-party liabilities, is the accidents or the auto insurance coverage. Our policy is we do not bill third-party liability because it can literally take years for some of those accident and cases to be settled. So by being upfront, having it in our policy that we do not bill third-party and that the patients are responsible for submitting the bills themselves and responsible for making payments on the accounts. If they do not, then their account can be sent to collections. Some attorneys' offices will provide protection letters, letter of protection, saying that once the case is settled, you're definitely going to get paid. You need to make a determination depending on your office if you accept those letters or not. Because like I said, that amount can stay open in your AR for years, depending how long it takes. Credit card fees, most banks directly deposit the amount on the credit card. But again, the fees usually range from 2% to 10% on each transaction. I know when we key our credit card payments in for patients, if we don't put like the 3-digit validation code on the back, if somebody's keying it in, if we don't put that code, we get charged an extra percent because we left it off. As if we key it in, then it's just the normal percentage. But being aware, and that's why some offices don't take American Express, because American Express nails you more like the 10% than MasterCard or Visa. So looking into, because, if they're paying you $20 and you're getting nailed 10%, that may not be our card that you want to accept. Credit card options, pay your bill online or e-payment, such as PayPal. Debit card, again, credit cards. I mentioned the medical card, care credit, that's pretty popular. But again, look at the fees and everything that are involved in it before you agree to accept it. On 336, an example, a Square device that can slide the card for credit card payments. Typically it's a machine in your office that you just zip the card through, or you key the information and they get a copy that needs to be signed by the patient with the amount, and then you give them a printed copy of what they sent in with a approval number and so forth. Debit card, again, very similar. It allows customers to withdraw cash and it's used very similar to a credit card, so you can accept that as well. That way they don't have to write a check, and you don't have to go to the bank. E-checks, another payment option. The patient gives you his or her checking account information, the bank routing number, a signature to confirm the electronic transaction, and the check is deposited immediately. Again, this is something that your office would have to set up and accept to do. May or may not, again, be something that's feasible depending on where the payments are accepted. Paper check validation. What's a good check? What's a bad check? If they're paying by check, this is saying checker ID, driver's license, at least checking one of them to make sure. Call the bank to verify all out-of-state or suspicious checks or have a verification process. Most of the patients we see are patients that we see frequently. With physical therapy, they're in 3 times a week. So we can get 3 checks from them. So as long as we're not getting those checks back as bounce, we're probably okay. If we started getting them back, then it's probably something we would address. Now, yes, if we start seeing a lot of patients traveling and they hand us an out-of-state check, then maybe it's possible if it was for a significant amount that I'd check with the bank before they left to make sure that it's going to be covered. Check forgery, false writing, alteration of a check. So to guard against forgery, check that the endorsement on the back of the check matches the name on the front. You do not want to accept, second, third-party checks or whatever. So if it's written out to, somebody else and they've signed it over to you, you also do not want to accept a post-dated check. If they say, well, I'll give you a check, but you can't cash it till Friday, they're writing you a check knowing there's no money in their account at the time services were rendered. Typically, good practice says don't do that. If the doctor says that, it's only 2 days away and he'll say, take the check, just don't post it till Friday, then I will do it. But rule of thumb says not a good practice to do. Problem checks appear in many forms. One is the check is for partial payment when they write payment in full. That's a big one. If you get a check and down in the line it says payment in full, so let's say the check is for $200 and you go in their account to post that check, but you see their account balance is $400. If they write payment in full and you cash that check for $200, you just ate that other $200 because they wrote payment in full. So to them, that's all they owe. You can argue until you're blue in the face that their account balance is $400. You can show that they received statements saying it's $400. But if they write payment in full and you cash that check, you have no leg to stand on if it goes to court.
Okay.
So usually they're the ones that are only going to come in the mail. So whoever's posting checks, I just make sure that they're aware of that. That if it says payment in full, make sure that that is the accurate amount that they owe. Otherwise, I've gotten ones that have said payment in full, and they owe more. And I'll call them and I'll say, I really appreciate your sending us this check for payment. You sent a $200 payment. Your account has a balance of $300. I cannot accept this check because you wrote payment in full. Well, what's the other $100? My bill says $200. Yes, your bill says $200 because that was last month's statement. This month's statement is $300. So I always just call and let them know so that we don't run into any issues. Again, post-dated checks. If it's like a couple of days, that's up to you. But federal collection law states if a check is dated more than 5 days in advance, is accepted, the patient must be notified no more than 10 days and no less than 3 days before the check is deposited. So again, if you're allowing them to post-date a check, you've got to call them to remind them that you're going to deposit it. Because if it's too far out and they forget, it's going to bounce. Unsigned checks, obviously, you are not supposed to do. Ask the patient to come into the office, sign the check, or send a new one. If you're unable to reach the patient, then write the word over or see reverse on the back of the check and send it back to them. Lack of signature required. Write your practice's name. Some banks will allow you to deposit by doing that lack of signature. Our bank won't. If we have a check that is unsigned or the amount is not written numerically and written out, I have to send it back to the patient or have them come in. They will not accept a check like that at all. Return checks. So when a check is not honored and it's returned to you, it's called non-sufficient funds. You can call the bank and find out if there are funds in there at the time you receive it back. They will send you an electronic version that is allowed to be redeposited once. So if there are funds available and you redeposit it that day, you're good. If they tell you there are no funds available, then you can call the patient and ask them. Typically, if it's non-sufficient funds and there are no funds available to deposit, we require that the patient come in and pay cash, because that way we're not getting another check that is bad. But again, you can, a non-sufficient fund demand letter can be sent certified mail with a check date, check number, name of the bank, name of the person that it was payable to, check amount, any allowable service charge, total amount due, and the number of days that they have to reply to you. So if you don't get anywhere handling it over the phone, you can send a non-sufficient fund demand letter. And again, if this is an issue, future payments can be in the form of cash, money order, or cashier's check. If you're notified that the checking account is closed, send a demand letter immediately. Most states, legal action can be taken if the patient doesn't respond in 30 days. So if you send that demand letter out immediately and they don't reply, you can act that much faster to get your money. When a patient stops payment on a check, it's usually done to resolve a good faith dispute. Patient believes that he or she has legal entitlement to withhold payment. So at this point, the physician may want to contact a lawyer to discuss their legal rights. Thank goodness, but I don't think we've ever had a stop payment on a check, which is wonderful. Every patient receives an itemized statement, and your itemized statement is going to say the date of service, what the billed amount is, what your insurance company paid, and what, if any, responsibility the patient owes. If you look on 339, this is a sample of a patient statement. So it gives the name of the practice. It says you can use a return envelope. Who the patient is, check if the above address is incorrect and indicate any changes. So that way, if it's going to a wrong address or being forwarded and we don't have it, if they're indicating that, we can change it when we get it back. Data service, the codes, what the description of the visit is, charges, payments on the account, and then what the balance is that's due by the patient on the bottom. Typically, we'll give a statement date, and this one gives the option of putting the credit card information, handwriting it on there, and sending it back to you. We can't do that because our statements are generated by our practice management system, which goes to a P.O. box. So if the credit card information goes to a P.O. box, they can't process the credit card payment, so they black it out. And then they send me a copy of this with it all blacked out, and I have to call the patient and get the information anyways. So what we did is we changed our statement to say, if you would like to pay by credit card, please call. And then they know that if they want to pay by credit card, that's the only way that they can do it. Professional bills are a reflection of the medical practice, so we want to make sure that it looks nice, which typically it will. Enclose a return address with the envelopes for which the payments can be mailed. And again, if there's a change in address or comes back to you as undeliverable, have a way to track that so that we can try to get that statement back out to a correct address for that patient as quickly as possible. Office is likely to experience increase in telephone calls when statements go out in the mail. So if statements are sent out, our old system used to generate statements twice a month, once at the beginning of the month and once at the middle of the month. So we knew when the phone calls would come in. Depending on your system, that can be different. Accounts receivable and age analysis. So this is a report that will check your AR, and it will age it 30, 60, 90, and 120 days or older. You can generate this in your practice management system, and it helps the collection follow-up. So when you run this, you can start with your oldest first, and anything that's over 120 days, typically you want to address first, and then move it back from there. Formula for determining AR is to divide the month-end AR balance by the monthly average charges for the 12-month prior period. An average total AR should be 1.5 to 2 times the charge for 1 month of services. So 90 days or older should not exceed 15 to 18% of the total AR. Our system is nice because our system will actually give us the percentages on the report when we run it of what's over 90 days old, so I can see if the percentages fall correctly. So if I have more, let's say I have 26% over 90 days, then that's what I'm going to focus on first because I know that percentage is too high. Obviously, your 0 to 30, that's nothing you need to worry about yet, but as it goes up, if the percentages go up too much, you want to address it. Dunning messages are phrases printed on statements to remind a patient about a delinquent account and to promise payment. Most effective collection statements are a handwritten note. However, that's not possible if you're sending them out in the system. So you can have electronic dunning messages that just say, for example, on page 340, there's a problem with your account, please call me at, give your number. The bill is now 30 days past due, please remit payment. 60 days past due, please send payment immediately. 90 days, please remit now to avoid collection agency. Or final notice, if we don't hear from you within 10 days, the account will be turned over. So you can create your own dunning messages according to what you want and how you want them worded. This particular one does, it looks like 4 bills, and your 4th one says the final notice. Some offices will only send 3 statements, and that 90-day one will say this is, will be sent to collection. So you should have a system in place that says how many statements you are going to send before action is taken. Don't send intimidating, impatient, or threatening statements. That's only going to make them mad. So no payment yet. Your payment by return mail will be appreciated. Payment needed now, no further credit to be extended. Those are ones we don't want to put on them. Just, bill is now 30 days past due, please remit promptly. Electronic media, you can receive emails about bills, but it's advisable that you don't respond via email due to privacy concerns. So have that a policy if you are going to receive electronic emails, if you are giving your email out there for a patient to send you questions about your bill, that you have a way of responding other than via email just because of security. So that's why most of the time people are just going to say, if you have questions, please call and put the number on the statement instead. Computer billing, again, most medical practices have your computer generate statements. They're generated by your software. Charges, payments, and adjustments will reflect on the copy available to mail to the patient. Computer program usually offers choices in billing types.
So including patient billing or insurance balance billing, billing according to types of adjustments, and no bill. You can instruct the computer to print all bills of a specific type. You can instruct it to print bills according to specific accounts or dates. Accounts are automatically aged, and standard messages can be printed on the statements of the aged accounts. And again, some systems allow you to personalize those messages. Some will come with those standardized messages. Others you can make your own. Billing services, so these are services or companies contracted to reduce administrative paperwork by taking over, submitting, and follow up on claims for the patients and for the office. They may provide data entry, billing information, charges, receipts, adjustments, tracking payments from patients and insurances, production of management reports, purging inactives, and collection of accounts. There are advantages of billing services, technology, professional understanding of bills, experts answering all billing-related telephone inquiries. The physician's office sends billing and receipt information to the system daily. They can run regular reports weekly or monthly. Most medical billing services charge a percent of every claim collected, typically 5 to 10%. So again, this is going to depend on whether the provider has somebody in the office and, they're paying overhead, they have to pay them benefits. If it's a provider that, wants low overhead and doesn't want to have to pay somebody benefits and the percentage is right, then they may rely on a billing service. But there are things to look at with that billing service. One, you've got to make sure they're HIPAA compliant. If the percentage of what they are going to charge you, if you don't do surgeries and you do low-cost office visits, is that percentage going to be worth them submitting the claims for you? So you can again see a collection tree about first, second, third, maybe the phone call after 90 days. You get a promise to pay, they pay it, or there's no attempt and you call them back, and then you send them to collection. Unable to contact, unwilling to arrange, you send a 10-day notice. You either get the payment or you send them to collection. On 342, billing procedures are determined on the size of the practice. So making sure we have a billing process guidelines in place that fit your practice. Check insurance and managed care contracts carefully to determine which circumstances allow for patients to be billed. Conform to federal guidelines if there's a need to bill managed care patients. You can see this is an example of a payment plan schedule, figure 1015. So if they owe $0 to $200, the minimum they can pay monthly on that is $35, and then it's paid off in 6 months. If they have a $200 balance and you're letting them pay $10 a month, it's going to take them 20 months before they get that account paid off. So if you have something standard like this, depending on the amount, you're more apt to get paid a lot quicker than if you allow them to set the amount. So payment plans is a way to allow them to pay off the account by spreading it out over a period of time. Sometimes offices will require a down payment. So if the balance is, $2,000, there's a down payment of $500, and then the remaining $1,500 can be split up over 6 months at $500 a month or $300 a month, whatever it works up to. Physician can take action, including sending the account to collection if a payment plan has been set up and it is broken. So again, having them sign saying they agree to pay this monthly. If they do not adhere to that, then that account can be placed for further collection status. When patients seek care from the medical practice and are honest about their financial status, this is when we have to get that financial plan agreement. So they have a clear understanding of the fees, what they are going to pay monthly, when the due date is, and what should happen if they do not pay that amount. If our patients get sent to collection because they don't pay their account, they can't be scheduled or come back until that account is paid in full. So if they adhere to the monthly payment plan, then they don't need to worry about that. Credit and collection laws. These are the legal framework within the insurance billing specialist that we have to execute our collection policies from. Most states have prompt payment laws for insurers and third-party payers to pay the insurance claims in a timely manner. You can see down at the bottom of 342, there's a red flag rule. That was set up by the Federal Trade Commission for businesses having more than 20 employees and having to issue credit to their clients. So if you qualify for being able to allow credit, so you're giving them the credit, you would want to make sure your office adheres to those red flag rules. Statute of limitations, those are time limits on legal action. So there is a maximum time during which legal collection suit can be rendered against the debtor. However, for a lawsuit to be successful, an effort should be made to collect on an account from the time services are rendered. The patient receives regular statements indicating that if the insurer does not pay, the patient will be held liable. Statutes vary according to three types of accounts. Open books, which are open charges made from time to time. Payment is expected within a specific period, but credit has been extended without a formal written contract. Written contract accounts have a formal written agreement in which a patient signs to pay his or her bill in like installments or the monthly payment. And single entry accounts have only one entry or charge, usually for a small amount. So for collections to be handled effectively, we should have collection techniques. And anybody calling that patient, if there's more than one person doing collections in the office, it should all be done the same way. Telephone collections are easier if the insurance billing specialist is convinced that he or she can collect before trying to convince the patient to pay. So two important factors to consider are their ability to contact the patient and the patient's ability to pay the bill. Contact the patient in a timely manner at the first sign of the payment delay. Prepare before making your phone call, so have the account up so you can see the information, let them know that when the last payment was, they missed their payment that was due 5 days ago, whatever it happens to be. Decide what amount will be settled for if payment cannot be made in full. Ask questions, show interest, let the patient know they're being listened to. So if they say, I can only make 1 month payment, they're behind 2 months, try to work with them. Respond in a respectful manner, carefully word your reply. We want to encourage them to pay, not make them mad so that they won't pay. And use your resources and learn to negotiate. Not negotiate the amount, but if they can't pay you today, would you be able to pay by Friday? I can give you a phone call then. Office policy, most organized approach to making collection calls is printing out that aging AR and work your 60 to 90 days or your 90 to 120 days. That usually works best. Start with the largest amount owed and work the accounts in decreasing amounts owed. And again, by age of the account, so your 90 to 120 days first. Most state collection laws allow phone calls between 8 a.m. and 9 p.m. Never call between 9 p.m. and 8 a.m. However, according to the collection experts, typically it's 5:30 to 8:30 when they're getting home from work. Maybe they're saying Tuesdays and Thursdays between 9 and 1, and maybe on Saturdays. But of course, Saturdays means you'd have to take a day off during the week. So if your collections aren't going real well during the week, that may be an option to work a Saturday morning instead of during the week to get those done. If you look on 344, 345, these are the federal collection and credit laws. So it's the Equal Credit Opportunity, the Fair Credit Reporting Act, Credit Transactions, Fair Credit Billing Act, Electronic Fund Transfers, the Truth in Lending Law, and Fair Debt Collection Process. So again, we want to just make sure that we are aware that we are within legal limits when we're following up on collection accounts. I went to a collection class once and they said if on your final bill you say if no payment within 10 days, account will be sent to collection, then in 10 days that account needs to be sent to collection because you can't threaten to do it and then not do it. So you have to have a way, if you're sending that on your statement, that you're following up to make sure that that happens. Use a private telephone when you're calling, away from busy operations of the regular office, because some patients don't like to talk about their bills around other people. Maybe it's in your office if they happen, to come to the office. Some offices will text message about their bills. That's not something that we do, but again, if that was going to be happening, I'd make sure you were within guidelines for doing so. Be careful when you call or text to not to include information that violates the privacy. So typically, this is so-and-so's office calling regarding your account. Please call, and then they can call you back. And then you go into the information about their account. Be alert for new ideas or approaches to collection by watching how banks or other companies do it. It may or may not work for you. There are improvements made to collection software. Again, whether or not that is a viable option for your practice. Some offices will do collection themselves, where they'll send out collection letters after the statements go out instead of hiring a collection agency. Making telephone calls so your telephone don't raise your voice and antagonize the patient. Do not accuse the patient of being dishonest or lying. Do not act like a tough guy or threaten. Do not consent to partial payment until payment in full has been asked for. Don't agree to a long string of partial payments. So again, if you have a minimum of $35 a month, don't accept $5 a month because you'll be accepting it forever. Don't engage in a debate, and do not report a disputed account to a collection agency or bureau until the patient's dispute is closed. So if they're questioning a charge or they're questioning that their insurance company paid it incorrectly, we want to make sure it processed properly and that they're truly due that amount before we would send that to collection if that happens to be the case. Telephone collection calls are effective on the day before patients are due in for their appointments, because that way we can remind them that they can bring the payment with them. Sometimes, depending on the amount, they may not be able to be seen unless a payment is made on the account. Collection letters. This is another way of reaching out to the patients. You can reach patients rapidly. The cost is relatively low if you use form letters. They do have some negative aspects. Negative aspects. It's a one-way communication, so you have the lack of the ability to provide the reason, or they have the lack of ability to provide the reason for non-payment. It can take 2 to 3 days to reach them, and then they may not even open it, depending on if they know what it is or not. Response and recovery through letters are relatively poor. Manual prep takes time, and then you have your cost of postage and supplies, and of course postage seems to go up all the time. The insurance billing specialist is often the one composing the letters and doing the collection follow-up. When collection letters are sent towards the end of the year, let the patient know if it's paid for by the end of the year, they can use it as an income tax deduction, for example. Sometimes if they've been paying monthly right along and Christmas is here and they can't pay in December, you forgive that month and allow them to continue the next month. Excuse me, on the top of 347 it talks, this was back to the telephone calls, but if the patient says, I can't pay anything now, these are some of the things you can say. Are you employed? Are you receiving unemployment benefits? Something like that. I can't pay the whole bill now. Okay, so how much can you pay and how long do you think it will take you? I have other bills. Okay, this is also one of your bills that needs to be paid. Let's talk about clearing this up. How about $10 a month on a $300 bill? I'd like to accept that, but we can only do so much a month, and this lays the blame on the accountant. So, that's a possibility. It's not, because if you're talking to them and you say we can only accept $30 a month, they're going to think that's you making that rule just for them. So by saying it's office policy or that type of thing, it takes the blame off you. I can't make this payment this month, so collection picks up all our delinquent accounts next Monday. I don't want to send it, but I do need payment today. The check is in the mail. They tell me the check's in the mail, that I asked for the check number and the date it was mailed, and I'll call them back if I don't get that check. And then that way I'm forcing them to give me information on that check. Because if they're telling you the check's in the mail, yeah, it may or may not truly be in the mail. What we will do is we'll leave off right there on the collection, types of collection letters. I didn't think we'd get all the way through it. We'll finish up next week with the collection letters and the collection agencies and small claims courts, bankruptcy, and estate claims. And then we will go into Chapter 11, which we are going to start talking about the individual insurance carriers. So we'll start with Blue Cross Blue Shield, private and managed care. And then we've got a chapter on Medicare. I believe we do one on TRICARE, workers' comp, and Medicaid. So we'll talk about the insurances and their guidelines. But next week we will pick up on 347 and we will go forward from there. Any questions over what we talked about so far regarding collections or anything like that?
No.
Nope. Pretty straightforward.
Really good ideas.
Yeah. You guys, I presume it's
the only one I'm interested. I can't wait until we covered the text. Did we cover texting?
Yeah.
That's one that I didn't. I don't see that one being very popular.
No.
Doing a text message, because that you have to do so much work to.
And
before
why
you even do that.
Right, and why do you want them to be able to have access to your personal phone number? Because you can't text from your office phone.
Right.
So that's just
the only thing I could see that working is if you had that capability, like within, like if you had a VoIP account that had that capability. Like I can see that being down the road if you were able to do that from within the system.
Yeah.
But that was just, I'll just cross that out. That's not
not something I'm going to do. I usually find that what works best for me is physically doing the phone calls, because a lot of times it's, you get, oh God, that's right, I completely forgot, I'm really sorry, or, they were out of town with an emergency, and you don't know, you sent the bill 30 days ago. Yeah, something could have come up, but I tend to find that probably, if I make 10 calls for collections, I'm probably getting at least 6 out of those 10. I'm getting paid something on those accounts.
Right.
So, that's better than leaving them or trying to send a letter and waiting for it to be delivered and then not being able to get immediate.
Do you use done messages on your?
On our bills, we have those pretty much. It's the standard one, so it says, your account is 30 days, and then it says your account is 60 days now past due. Please remit promptly. And then I think the last one says your account is now 90 days overdue. Please remit payment promptly, or account may be placed for collection status or collection action. And then, if after 90 days, rather than generate another statement threatening the collection, I do the phone call. And I say, you've received 3 statements. Unfortunately, your account is due to be placed for collection. We need to receive, if they're on a payment plan and they're behind, then it's the current amount to get the payment plan current, or it goes, or we need some sort of payment, and then we set up a payment plan on the rest of it.
Right.
So,
okay.
Yeah, but typically it's the standards, and then I do the after 90 days is the phone call.
Okay. Interesting. I like. Sounds good.
All right. Well, we will see you next week then.
Okay. So
All
we
right.
need to we should have completed 9, and we should have completed at least 9 and the exam for 9, and then most of the work for 10.
Yep.
By next week, correct?
Yep.
Okay.